Afternoon, everybody. I hope you guys had a good time, good food for lunch. And my purpose is to keep you awake for the next 15 minutes. So my topic is ST segment elevation myocardial infarction. As a first or second year fellows, this is probably a very anxiety-provoking call if you ever get a call from the ER or someplace to go and evaluate ST segment elevation MI. My goal is to help you with the with the certain initial aspects and the treatment regimens available to take care of these patients. So first thing is ST segment elevation MI. The diagnosis has to be in a clinical setting that sort of is suggestive of acute coronary syndrome. So you have to look at the patient's symptoms for diagnosis. You have to look at EKG for ST segment elevations. And you have to, these patients will have subsequent release of biomarkers. Obviously, you cannot wait for the biomarkers to return. So your diagnosis will truly depend on patients, evaluating the patient's clinical scenario and the patient's and the EKG. There are some EKG diagnosis criteria which are listed below. If you look at the leads V2 and V3 have a slightly different criteria compared to the rest of the precordial and limb leads. In lead V2 and V3, your criteria will be 2 millimeters in men and 1.3 millimeters or more ST elevations. Whereas in rest of the leads, you have to have at least 1 millimeter ST elevation in 2 contiguous leads. And EKG is not sometimes very clear. And a lot of times, like I said, your clinical scenario will truly help you determine the diagnosis. And if you ever have any questions, the guidelines document also recommend to incorporate additional diagnostic information by doing a bedside echocardiogram, etc., to help you. So in this EKG, like you said, if you can read, this is a 50-year-old female who presented to the hospital with chest pain, abdominal pain. Her initial cardiac enzymes were elevated. Her initial EKG, as you can see, was fairly unremarkable. But over time, the next day, her EKG became dramatically abnormal. So what do you think about this EKG on the next day, 25th? So it's got dramatic, it has ST segment elevation throughout all the precordial and limb leads. There's some ST segment depression going on. So this is the kind of patient where you really want to have additional information before you activate the ST segment elevation alarm. So in this patient, we did a bedside echocardiogram that showed normal wall motion abnormality in all the leads. She had moderate pericardial effusion. And the overall scenario over the next 24 hours developed into giving us a diagnosis of pericarditis. But I can tell you in the real world scenario, it's really difficult when you really are the one making the decision. So always get the help of additional information if you need it. This is a patient 54-year-old patient who presented with nausea, vomiting to the emergency room. As you know, pretty much everybody gets an EKG. No matter what, even if they come with a toe pain, sometimes they get an EKG, and then you sort of are the one to make the decision. So this patient had presented 3 months earlier. Her EKGs was fairly unremarkable at that time, was some atypical chest pain. But this time, his EKGs has ST segment elevations. So as you can see, the EKG has a ST segment elevation, right bundle branch block type of pattern, and coved up ST segment elevation of V1, V2, V3, and some ST segment depression in some of the other leads too. So this patient was a STEMI was activated, and by the time we were doing the angiogram, a nurse called and said, patient's potassium is 8.2. And in the meantime, in about 30 seconds, we had an angiogram that showed normal coronary arteries. So going back, this patient has a very typical EKG of a Brugada syndrome. And plus, obviously, some EKG changes of potassium elevation too. So consider that in your differential diagnosis. This is I apologize, the EKG is not turning out very well. This is a 58-year-old patient who presented with chest pain and shortness of breath. And the EKG is, in this case, is actually completely normal. This is a normal-looking EKG that has no ST segment elevation in any of the leads. But the patient is having chest pain. His worst chest pain has actually started since yesterday. So he was taken to the cardiac catheterization lab, and even when he was having the chest pain with a normal EKG, he has an occluded circumflex territory. And there is actually several studies that have looked at circumflex territory being silent on a 12-lead EKG, unless you consider doing left lateral leads. In these cases, and this might have been the case where you might have picked up ST segment elevation in V7, 8, or 9. To consider doing that. This is a 37-year-old male smoker with diabetes, hypertension, who came with chest pain. Started 30 minutes ago, and you can see there's about 2 millimeter ST elevations in the inferior leads and some ST depressions in the lateral leads, suggesting a diagnosis of inferior wall myocardial infarction. There's no ST depressions in V1, V2, V3. So I don't think there's any posterior wall involvement in this case. So lo and behold, he has a mid-RCA occlusion, which was treated with a PCI. So STEMI EKG changes will localize the vessel infarct artery. This is a 64-year-old male with chest pain from 30 minutes ago. 53-year-old male with the left shoulder pain since yesterday. Lasted for 1 hour, resolved, and came back. It's typical history of a lot of patients with stuttering pain. Finally, they come to the emergency room. In this case, you can see there's ST segment elevations in the anterior leads, but most of them are also present. Q waves are also present in all the leads, and then reciprocal changes. So this patient had a proximal LAD occlusion, which was treated. So anterior ST elevations with the LAD territory MI. This is a EKG, the post-PCI, that showed significant improvement. This is a different patient, 62-year-old female, hypertension, was intubated in the field because of severe shortness of breath, flash pulmonary edema. And this patient, there is a dramatic ST segment elevation in the anterolateral leads. So this will suggest you of a proximal LAD occlusion. So this patient had that, and you go in to treat the LAD. This is a 47-year-old male with nauseous vomiting and nauseous sweating. And this patient has a ST segment elevation in the anterolateral leads. But these EKG changes are very dissimilar to the previous one. Again, this is ST segment elevation in the anterior lead, but here the ST segments are not as dramatic, but it's still suggestive of anterior wall MI. Similar to the last case is a proximal LAD occlusion. So two different presentations of an LAD territory infarction. This is a 57-year-old male who has been having chest pain, and in this case, you have a prior EKG and a EKG shows, in this case, only is showing lateral ST segment elevation in V5 and V6. There's no other EKG changes. So here you have a diagonal involvement or an obtuse marginal involvement, and which was a large obtuse marginal that was occluded right here. And aspiration thrombectomy was done, followed by PCI, and this is the territory that was involved. So V5 and V6 associated with OM occlusion. This is a 73-year-old female nursing home resident. Your information that you receive is basically the patient was short of breath, EMS was called, patient was intubated in the field and brought to the emergency room, and the EKG shows anterior ST elevations. And so consider Takasupa's stress myopathy, which is associated with ST segment elevations. This patient has normal coronaries. This was a STEMI activation from the emergency room. I apologize, this patient does have ST segment elevation, which are very faint, don't meet the criteria of the 2 millimeters, but the computer is calling acute MI. When the computer calls acute MI, the ER will always activate the STEMI. They almost never wait back. So even if the EKG is not truly abnormal, now you're stuck with a patient who has no good history. Patient was intubated in the field, questionable tachyarrhythmia, but it's sort of equivocal EKG. So in this case, whenever you have an equivocal EKG in a patient who's not very responsive, and a patient has a collapse in the field, consider additional diagnosis. And luckily in this case, we send the patient to a CT scanner before bringing him to the cath lab, and he just waited. He went from a CT scanner back to the ER for further management. He had an intracranial hemorrhage. Very similar story. A few weeks later, we had a patient who was brought to the emergency room by EMS. EMS said that the patient had a questionable seizure in the field. Somebody called the EMS. He was brought, sedated, arousable, but not giving any history. And you can see he got ST segment elevations. And the EKG is also saying acute MI. So here, similar scenario, be very careful, consider additional diagnosis. And this patient underwent for CT scan of the brain and had a subarachnoid hemorrhage that was causing EKG changes. So very important to remember this differential in your diagnosis of acute MI. And frequently, you can have acute pericarditis, LVH and left bundle branch block can cause you make the EKG equivocal for diagnosis, and Brugada syndrome, intracranial hemorrhage, and myocarditis, and stress myopathy. So overall, STEMI diagnosis, STEMI is about 30 to 40% of the acute MI, acute coronary syndrome cases. The population-based incidence, age and sex-adjusted incidences are for STEMI are actually decreasing. For non-STEMI, ACS are increasing in the population. There's a great deal of stress in the guidelines and several papers about reducing the total ischemic time. It's very important as a physicians for you to educate your patient not to wait with chest pain at home and try alternative therapies before they call EMS. Patient with high risk of having acute coronary syndrome should be educated to call EMS early. There's a benefit of EMS transfer compared to private vehicle because EMS can activate the ACS treatment to support the patient, and patients door to balloon first medical contact to balloon times are quicker that way. And frequently, about 1 in 300, according to the data, patients will suffer acute cardiac arrest if they're in a private vehicle. So with the EMS, they can be treated. In the past guidelines, there was a great stress on IV beta blockers, and no longer there's a caution there's a class 1 indication for oral beta blockers to be used, but you should remember to avoid using them in patients with signs of heart failure, those who are at higher risk of having a cardiogenic shock, or those with heart block, asthma, or reactive liver disease. Reperfusion therapy, most important component of STEMI management. There's two options, primary PCI versus fibrinolytic therapy. Primary PCI, either one is recommended as a class 1 indication within 12 hours of symptom onset. The goal of therapy for primary PCI is to perform first medical contact to device time of less than 90 minutes. If the patient arrives at a hospital that is unable to provide primary PCI, these patients should be transferred for primary PCI if there's a consistent and well-documented method of achieving a first medical contact to device time of less than 120 minutes. So, and these system has to be validated over time and make sure that you're able to achieve this transfer times 90% of the times to meet the criteria. So fibrinolytic therapy, if the patient cannot be transported to get primary PCI within 120 minutes, then fibrinolytic therapy should be administered within 30 minutes of first medical contact. And patients who have had symptoms of more than 12 hours, between 12 to 24 hours, is class 2, actually it's 2A indication, 2A indication level of evidence B to perform primary PCI. In these patients, you can also do fibrinolytic therapy. Primary PCI is absolutely not available, but primary PCI is more preferable. Those with shock or severe heart failure should always be transported emergently for primary PCI, regardless of the amount of weight. So this is the flow diagram that shows the preferred methods for transport, for taking care of STEMI patients. If a STEMI patient who has a candidate for reperfusion is initially seen at a PCI-capable hospital, they should achieve a first medical contact, a device time of 90 minutes. This is a system goal for individual patient. The lower time, the better, because time is muscle. Those who are initially seen at a non-PCI capable hospital, they should be transported, preferably if the less than 120 minutes goal could be achieved. But if that is not achievable, then these patients should be given fibrinolytic therapy within 30 minutes. After that, you have two options. You can either Transport, there's a 2A indication for both of them. There's several trials that have looked into this. You can transfer this patient for PCI, for catheterization and plus minus PCI to be done within 33 hours to 24 hours. Or you can only wait for the patient to transport only those patients who have had failed reperfusion for PCI. So these are the class 1 indication for primary PCI. Ischemic symptoms of less than 12 hours. Ischemic symptoms of less than 12 hours who are not candidates for fibrinolytic therapy. And those who are in shock or heart failure. And those who have evidence of ongoing ischemia within from onset of symptoms of 12 to 24 hours. And those patients, like I mentioned, who cannot achieve the first get to a hospital without primary PCI capability and cannot be transported to achieve primary PCI within 120 minutes, these patients should be, there's a class 1 indication to give fibrinolytic therapy within 12 hours. And if symptoms have been more than 12 hours, then preferably PCI is still preferable. But again, if it cannot be achieved at a reasonable time frame, they should be receiving fibrinolytic therapy. Fibrinolytic therapy should not be administered for ST segment depression. There's only 2 scenarios where you might consider fibrinolytic therapy. One is the true posterior MI, where there's ST segment depressions in the V1, V2, V3, suggestive of true posterior MI, or you can have ST segment elevation in AVR with ST segment depression in the rest of the lead. And that is usually has been shown to be suggestive of left main or proximal LAD occlusion. Then if you do primary PCI in these patients, you have to consider antiplatelet and anticoagulant therapy. You always should want to give these patients aspirin immediately and continue long term. Then you have a choice of 2B3, P2Y12 inhibitors, which are oral antiplatelet agents. You have a choice of give to class 1 indication to give Plavix, clopidogrel, prasugrel, or ticagrelor, either one of them. You want to avoid prasugrel in patients who have a prior history of TIA or stroke because of risk of harm. So that's oral antiplatelet agents. So you give aspirin, one of the P2Y12 inhibitors, and then there's a 2A indication to use 2B3 inhibitors IV. And with the most recent data in the most recent trials, with the presence of more potent antiplatelet agents, use of 2B3 inhibitors is class 2A. And usually they are selectively used in patients where there's slow flow, large thrombus burden. There's an option to give intracoronary obexelimab. There's a few studies that I've looked at. There's class 2B indication for that. And pre-catheterization administration, cath lab administration of 2B3 inhibitors is considered class 2B, based on a few data that shows that if you give this, there's a higher rate of patency of the vessel at the time of angiogram. Then, in terms of that was antiplatelet agents, you always want to have one anticoagulant at the time of the primary PCI. You have an option to give class unfractionated heparin or bivalve. Bivalve therapy is preferable, particularly from femoral access. Those patients who are high risk of bleeding, and if you are thinking of using unfractionated heparin and glycoprotein 2B3 inhibitor, bivalent monotherapy might be preferable in those cases. But there's still controversy regarding how long to, particularly in patients who have not received dual antiplatelet therapy prior to your procedure, they may need bivalve longer in 2 to 4 hour infusion after these primary PCI. Fondaparinux is not recommended as a sole agent for anticoagulant for primary PCI. Then aspiration thrombectomy, the data shows that most recent data shows that there is 2B class 3 indication for routine and 2B indication for selective and bailout. Culprit was there's several studies recently that have shown that in the past it was a class 3 recommendation. Now it's a class 2B recommendation to use culprit arch multi-vessel PCI at the time of the primary PCI, or during the same hospitalization, or as a staged procedure. What do you do? But there's a lot of controversy in addition regarding the access, radial versus femoral. There's a significant amount of data, particularly in a STEMI population, that shows that a radial access in a STEMI patient reduces mortality, all-cause death, MACE, and major bleeding. And if you combine radial access with bivalirudin, has the lowest numerical value in terms of having major bleeding. These are the 3 fibrinolytic agents that have been used for patients with STEMI. TNK has the simplest way of administration, the single IV-based bolus, weight-based bolus. Patients receive fibrinolytic therapy. They should be given antiplatelet agent and anticoagulant agent at the right after the fibrinolytic agent. Very important to remember. Newer antiplatelet agents and glycoprotein 2B3 inhibitors should be avoided because there's not much data regarding their use. And should we send these patients, all patients who have received fibrinolytic therapy for early revascularization versus ischemia-driven revascularization? As you can see, that these trials that have looked at this for angiography and PCI of the infarct vessel after fibrinolytic therapy shows lower rate of primary outcomes in patients who received angiography within 24 hours. So that's why there's class 2A indication. Then there's a class 3 indication for patients who have delayed PCI of a totally occluded infarct vessel after 24 hours of STEMI. So these are that's for stable patient. So that data comes from the old trial. So if you could do an angiogram after 24 hours in a STEMI patient and you have a totally occluded vessel, it's recommended to have an ischemia-driven revascularization instead of opening up the infarct vessel after 24 hours. Then what you have to give, what kind of adjunctive therapy can you use for PCI in patients who have already received fibrinolytic therapy? The data suggests that if patients have received loading dose of clopidogrel, they should be given clopidogrel, continued clopidogrel without an additional bolus. Those who have not received the clopidogrel bolus should be given bolus at the time of the PCI, 300 milligrams if the lytic therapy was within 24 hours, 600 milligrams of lytic therapy was more than 24 hours. And they should be continue using unfractionated heparin or enoxaparin at the time of the PCI. Fondaparinux is not recommended as an agent for. Cooling is recommended for STEMI patients coming in with cardiac arrest with VFib or pulseless VT, and they should be cooled for up to 32 to 34 degrees centigrade for 12 to 24 hours. It's shown to improve the neurological outcomes. So take-home points, differential diagnosis of resting segment elevation MI is very important to keep in mind. Primary PCI is a preferred reperfusion therapy. You should educate the patient to activate EMS with the onset of chest pain that doesn't go away after 20 to 30 minutes to reduce the total ischemic time. Consider fibrinolytic therapy in patients with a golden hour, those who present early within 1 to 2 hours of symptom onset, especially if they have low risk of bleeding. Consider bleeding avoidance strategy, which are radial access and bivalirudin for primary PCI. And oral dual antiplatelet therapy after STEMI is recommended for minimum 12 months in patients with or without stenting. Thank you very much.